So now, without further ado, let me introduce you to our speaker. We are super excited to have Dr. Christian Helfrich here. He is an implementation scientist and a core investigator at the Seattle-Denver Center for Innovation for Veteran-Centered and Value-Driven Care. He studies organizational change and implementation science in healthcare and how to design and evaluate strategies to reduce low-value practices. Thank you very much for joining us, and it's all yours.
Fantastic. Thank you, Dr. Tija, and thank you, Dr. Bookvar. I appreciate the invitation to join you all today. And so I'll be talking about de-implementing low-value care. And from my perspective, I think of de-prescribing as a type of de-implementation. There are probably some differences. It may be that the Venn diagram of de-prescribing doesn't fit perfectly within de-implementation, but I think there's a lot of overlap. And so I'm going to be talking more generally about de-implementing low-value care, but we'll touch on the example I'll use is about medications. And I think these lessons are very applicable to de-prescribing low-value medications. I've just a disclosure, I've got no relevant financial relationships or non-financial relationships to anything described here. And then this work, a lot of the ideas that I'm describing came out of work that I was lucky enough to do with a large team as part of a VA Quality Enhancement Research Initiative, or Query Grant, Quality Enhancement Research Initiative. We ran a program called the Quality and Safety Query. David O and Christine Hartman and I were PIs. And this work is, again, really reflects the collective work of this broader team. I love this quote from St. Augustine: "Falor ergo sum." It's a little bit of like Descartes, "I think, therefore I am. I err, therefore I am." And I think that is very true for anything we do, any human endeavor. And that's what oftentimes leads us to this place where we have a low value practice. I'm going to be talking about some concepts, some sort of abstract concepts, what Dr. Tija mentioned in the title. Psychological reactants, routines and heuristics, and asymmetry of outcomes. And I think it may be best, maybe easiest or most informative if we actually start with a vignette about a particular low value practice. And in this case, an inhaler for chronic obstructive pulmonary disease. So it was a Monday morning, and Dr. Bott, a primary care provider at a clinic in the Skagit Valley of Washington State, was preparing for her day by pulling up the electronic health records for the patients she would be seeing that day. And for one of her older patients, Mr. Larson, she saw a new note in his electronic health record from a pulmonary team at the regional medical center that her clinic was affiliated with. And that pulmonary team at the regional medical center, the note said, was doing a routine review of patient charts for patients who had chronic obstructive pulmonary disease and who had been prescribed an inhaled corticosteroid. And Mr. Larson was one of these patients. As Dr. Bott was reading this note, she remembered the inhaled corticosteroid because Mr. Larson had been prescribed the inhaled corticosteroid after an emergency department visit that he had for breathing difficulty. And this visit happened while he was traveling to visit family. And when Mr. Larson returned with the inhaler, Dr. Bott was somewhat confused by the prescription initially. It's not what she would have given him. She had already had him on a combination inhaler of two long-acting agents that she had read at one point were the current standard of care. But she also knew she wasn't a COPD specialist. COPD treatment guidelines had become significantly more complex in recent years. There may have been changes she wasn't aware of, and she was reluctant to second guess the emergency department physician who may have had other information that she had access to. And that decision may have been based on information that she didn't have. However, now Dr. Bott was reading the pulmonary team's notes, and they said that this innocuous inhaler actually posed a small but real health risk to Mr. Larson. And they explained and cited a study. They said that for every approximately 62 patients on an inhaled corticosteroid plus long-acting agents, within a year, you could expect on average about one of those patients to contract pneumonia who otherwise wouldn't if you just had them on the long-acting agents. So a number needed to harm of 62, an annual number needed to harm of 62. And for a patient of Mr. Larson's age, of course, pneumonia is not insignificant for anyone, but particularly for a patient of Mr. Larson's age and his history of breathing difficulties, contracting pneumonia was a really serious risk. So the pulmonary team had included this explanation of the harms. They had linked to relevant guidelines, and they had also included an unsigned order that would go to the pharmacy with instructions on how to de-implement the inhaler, to separate the inhaled corticosteroid from the long-acting agents and to gradually titrate it down. And they'd left the note unsigned. They co-signed it, but they left it unsigned for Dr. Bott, and it was her call to sign the order and to go forward with de-implementing the inhaled corticosteroid or not. On the one hand, the team's note vindicated what she had originally felt about the inhaled corticosteroid, her doubts about it being the appropriate care for him. But now she still felt a little bit of uncertainty with going forward with the pulmonary team's recommendation. Mr. Larson was an anxious patient. He'd been through several health scares in the past couple of years, and he was doing well at the moment. She briefly thought, why rock the boat? However, later that morning in the exam room with Dr. Larson, she decided to bring up the inhaled corticosteroid and proposed taking him off of it. And she explained why she was recommending he no longer use the inhaled corticosteroid, using language the pulmonary team had provided. And he seemed to understand. He was nodding his head, but she sensed he was apprehensive. And she asked if he had thoughts or questions, or if there was something that didn't sound right about the change to him. And he said that he understood there were downsides to the medication. He seemed to generally understand that medications were not unambiguously good. But he said, it's like a security blanket just to have here in case I should get into some kind of a scenario. And she asked him what he meant by getting into a scenario. And he talked about the trip to the emergency department where he couldn't breathe and shared that he thought he was going to die. Dr. Bott listened. She nodded. She reflected back what she was hearing to him to make sure that she understood and to make sure that he felt like he was understood. And then she shared her concerns that the inhaled corticosteroid not only was it not going to prevent him from going to the emergency department, it actually might be the cause of him going to the emergency department. She worried that the inhaled corticosteroid wasn't doing anything that the other medications weren't already doing, and that it was this risk to him. And she pointed out that the plan was to have him gradually reduce the inhaled corticosteroid. That's what the pulmonary team had recommended. And she proposed that they could start doing that. They could start that reduction, titrating him down, and then talk again at his next visit about how it was going. And if he felt like his breathing was getting worse, then they could go back to having the inhaled corticosteroid, or they could come up with some other plan, some other way of approaching it. It didn't have to be an all or nothing choice. And at the end of the visit, Mr. Larson agreed, and Dr. Bott electronically signed the order to change the prescription. That conversation had taken over 20 minutes. And as she reflected, she thought at the community clinic she was working in now, the providers had some latitude to take that long for patients. They could move things around. But at the private primary care clinic where she first practiced when she got out of medical school, got out of residency, that would have never happened. She would have had to either accede to Mr. Larson and keep him on the inhaled corticosteroid, or she would have had to peremptorily cut the conversation short and say, no, I'm the doctor, I'm taking you off the medication. This vignette is fictitious, but it's actually based on a de-implementation program that we did that David O led in the VA at two medical centers at VA Puget Sound and Boston Bedford VA. And some of the quotes, including the quote about rocking the boat and the patient's anxiety, feeling like the inhaler was a safety blanket and was there in case they should get into some kind of scenario, those come from provider and patient interviews we conducted with participants in the study. And this de-implementation program may serve as an example of one systems intervention, one effective systems intervention that can be broadly useful for de-implementing low value care. And I'll be happy to share more information about some of the publications from that particular intervention, this proactive e-consult by a pulmonary team. But one of the things that I think it actually brings up are some of the underlying dynamics in de-implementation that make it different. And there are three of these, like the title of the talk says. There are three of these that I want to dive into a little bit. This role of routines and heuristics, asymmetry, what I call asymmetry of outcomes, and then psychological reactance. And I'm going to get into each of these. And this is a little bit taking a step back, but I want to just make sure that we're all on the same page. Again, this is the de-prescribing network. I think you all are probably have had some exposure to the broader idea of low value care, but just to share some definitions from my perspective, this is how I'm viewing the world to make sure you understand. But I think of low value practices as broadly healthcare and public health practices, and for that matter, we could think of this more broadly as any sort of public policy or program or virtually anything. But I think of it as a public health or healthcare practice or program that fails to provide a benefit, or where the demonstrated risks, the known risks outstrip or outweigh any expected benefit from the program. And there are some nuances between low value care and what's often called medical overuse to distinguish it from underuse, where we fail to deliver evidence-based care, or misuse, the misapplication of best practices. I generally use overuse and low value practice synonymously. I use it interchangeably. Just be aware that that actually there are some distinctions that scholars in this field draw. I think we can also think about low value care in a slightly different context. This is something that Don Berwick and Hackbarth have written about previously. And it's this idea that oftentimes there is some ambiguity about care. There's ambiguity about the benefits of, for example, cancer screening. And what Berwick and Hackbarth have proposed is this idea of care that also fails to accord with patients' and clients' preferences. And the way that they articulate that is, if we imagined, if patients knew the cost and really understood the cost and benefit of a care, if they knew what it was going to end up costing them, that there were downstream consequences, for example, that there was even a possibility of downstream consequences, and if they knew the true advantage, delivered by healthcare, would they actually choose it for themselves? And I think that what Berwick and Hackbarth argue is there's actually a bunch of care that we probably won't define as low value care because there's not a demonstrable harm for everyone. There's a lot of gray area, but there's a lot of care that they argue actually does meet the criterion of low value care, that if a patient actually had insight into what they were getting, they probably would choose not to get it. Anyways, I just mentioned these sort of two definitions, and these are definitions that they've really influenced me. And then when I speak of de-implementation, I'm talking about systematic efforts to try to stop doing practices that there's some consensus are low value. So not just like an individual clinician deciding to curtail some practice, but some sort of systematic effort, a team, for example, a clinic, or a policy or program. And a great example of that, of course, is the Choosing Wisely initiative championed by the American Board of Internal Medicine Foundation. And when we talk about de-implementation strategies, we're really talking again about deliberate strategies. And I will just mention, again, there's a really interesting literature on extinction, practices. And this actually just happens all the time naturally, as we have new technologies that emerge and replace old technologies. And there are practices and technologies that simply, go out of style and become extinct or largely extinct. And I think of de-implementation as something very different than that. A couple of other things I'll just mention. This is a broader background, and I'm sure that you all are very well versed in the literature on the extent of things like polypharmacy, or the extent of the misprescribing of antibiotics for things like simple upper respiratory infection. I think the broader literature on low value care, I think that there are a couple of things that are useful to recognize about this literature. One is that it's just highly context dependent, right? You'll see different different levels, different prevalence of low value care in different settings, different patient populations, different regions, different time frames. So it varies a lot. On the other hand, low value care, anytime there have been systematic efforts to measure low value care, and even when the the criterion for defining something as low value care is very conservative, meaning they're not going to, the reviewers, those conducting the review, like a chart review, are only going to determine something as low value if they really believe that there's no sort of generous interpretation that would make it high value care. Even in those cases, we still see it in a substantial proportion of patients, somewhere around 10%, 15% of patients or incidences of delivery of the care. So I just want to mention that. I'll also mention we lack, we lack information on low value practices. But again, everywhere we look for it, and there's some fascinating work out of public policy and global development on ineffective programs, and there are really astonishing examples of literally hundreds of millions of dollars being spent on programs that ultimately are totally ineffective, sometimes counterproductive, but totally ineffective, and where there was either no evidence to warrant scaling up the program in the first place. The DARE program in the United States for de-implementing or for reducing child and teenage drug use is a great example. Anyway, so it's just a very prevalent problem. The other thing that I just note briefly, there was a lit review by Schrank and colleagues in, I believe it was in JAMA in 2019. It's a useful read for anyone, probably for all of you if you haven't seen it. But they tried to articulate different categories of healthcare waste. So this is far beyond their lit reviews, far beyond just low value care overuse. It was all kinds of waste, including things like administrative inefficiency. But low value care in overuse was a specific category they looked at. And one of the things they tried to do is estimate what proportion, not only estimate a dollar amount of waste occurring in the U.S., but also to estimate how much of that waste could be curtailed through existing known programs. And there are all kinds of assumptions they made, and you can imagine, there are lots of caveats, but it's a really interesting, it's an interesting perspective and an interesting exercise they went through. And again, for anyone working in this area, I think it's really worth digging into what they did and trying to understand. And the top line, takeaway is they concluded somewhere between 75 billion and 101 billion dollars in the U.S. Every year went to low value care practices that either did no good whatsoever, or where the expected harms, demonstrated harms outweighed the benefits. And they estimated that somewhere between almost 13 billion and 12.8 billion and 28.6 billion could be saved from already proven interventions. Again, some big caveats, but that's a really important paper to look at. I'd like to just briefly talk about drivers of low value care, and again, I think this is no doubt something that y'all are familiar with in the context of deprescribing. But we, I think that, and we'll get into this a little bit with routines and heuristics, but we know that practices, oftentimes in any profession, you establish some baseline of practice through your training and informal mentoring, and often in your first practice setting. And those patterns of practice will get set very early on, and it can take a lot. And again, we'll get into this. This is exactly one of the things I want to dive into a little bit. But we refer to those as tradition-based practices, and once established, they can be challenging to change. One of the things that I think we underappreciate, under communicate within the scientific community is we're also standing, we're building our evidence-based practices in some senses, not in all senses, but in some senses on a foundation of sand, because our facts are constantly evolving. And it doesn't mean that there's something called the pessimistic meta-induction. Basically, we've had our whole history of science is basically scientists iteratively discovering ways that they were wrong and correcting, correcting errors. And so there, from one perspective, the perspective of those who advocate the pessimistic meta-induction, science is flawed. Like we have every reason to believe that science is just an ever continuing, not unending process of people being wrong and having to revise their beliefs. And that's not true, because science iterates and builds. And there's a great idea actually promoted by Isaac Asimov, the author. Sorry, I mispronounced his last name, but about the relativity of wrong. If you look up I believe he had an essay called "The Relativity of Wrong," and basically in science we get less and less wrong. We continually refine our understanding of the world, and we squeeze the error, the bias out of our models, out of our understanding, if we work collectively as a community to challenge and systematically challenge and test our ideas, our suppositions. But one of the consequences of that is our facts do evolve over time. And there is this idea of actually within science, we can't tell what facts are going to be overturned in the future, but we do know we can actually calculate a rate by which our facts are overturned. We can look at the past, and we can base the frequency of facts being overturned, and we can come up with an estimate and have an understanding of how often our science basically shifts under our feet in some meaningful way, where we need to revise our understanding and revise our practice. And there's a great book, Samuel Arbesman has a fantastic book called The Half-Life of Facts. I highly recommend it. I think he may have done an article. I think he may have an article that covers many of the same ideas. I could be wrong about that. But there have been a number of literature reviews that have attempted to basically calculate this half-life effects. And one of the I find just one of the most intriguing ones, and one of the earliest I've been able to find, was this lit review by Hall and colleagues in surgery that came out in 1997. But basically looking at the half-life effects in surgery, and this was not a comprehensive review. They took I think it was a handful of leading surgery journals, and then just selected a set of practices that they thought were sort of emblematic of surgical practice, and then did a review and looked at when understanding about them changed and treatment decisions changed. And they concluded somewhere around 45 years was the half-life effects, that half of those facts that after 45 years had either been overturned or substantially revised. And again, the point of this is not to sow seeds of doubt about the scientific underpinning of medicine, but to have some realistic expectation that the sets of guidelines that we practice medicine by today, and I say we, I'm not a clinician, that we collectively practice medicine by, or surgery, or public health guidelines, those are going to change in some important ways. And then finally, I think we need to be, as a scientific community, we need to be aware of and at the forefront of combating corruption in science. And there are two things that I want to point out. One is the crisis of reproducibility, or reproduction, the reproduction crisis. And if you're not aware of it, look up the Open Science Collaboration. This was published in 2015. This was in psychology, but an effort to replicate some of the foundational studies, modern studies in behavioral science, and it was just an abject failure. And it's just psychology is different psychology is different than medicine. But there are some really good reasons to believe that this crisis is widespread, even in the hard sciences. This occurs in chemistry. There are examples of this in chemistry, in physics. Ritchie, I can't remember Ritchie's the first name, again, has a book. I don't remember what it's called. These slides will be available, and that book is in the citations at the end. But the reproducibility crisis is absolutely key, and it's far beyond the scope of my talk today, but something we really need to understand. And then of pseudoscience, and we saw that in just in all of its glory with the COVID pandemic. There's something called Brandolini's law. It's also called the bullshit asymmetry theory, which I love. And it's basically the idea that it takes virtually no energy or very, very little energy to produce just completely made up results. It just takes very little effort, but to actually do any sort of systematic effort to combat, any due diligence to combat pseudoscience is extremely labor intensive, and it creates this, again, this asymmetry. We're going to talk about asymmetry of outcomes, which is different, but it creates this asymmetry between science and pseudoscience. And both of those things, I think, are profound issues right now in our public health and healthcare practice. I'm actually going to jump over these and get into these three aspects that I'd like to touch on, and that's the role of routines and heuristics, asymmetry of outcomes, and then psychological reactance in low value care. So, and when I talk about heuristics, I mean mental shortcuts or patterns of behavior, things that we develop over time in response to encountering the same task or problem. And it's basically a shortcut, and it allows us to do things more efficiently. And actually, again, this is way beyond the scope of my talk today, but interestingly, I think there's some good evidence from cognitive psychology and studies of expert performance. There's also good reason to think that mental heuristics are more effective. So not only more efficient, that's generally accepted, but in certain instances, they're more efficient in trying to get someone who actually really understands a topic deeply to sort of get out of their head, as it were, and to consciously reflect on decision making, can lead them to make worse decisions. And again, I'd be happy to have people follow up about that afterwards. I can recommend some readings. There's some Anders Ericsson has some fantastic readings on exactly this topic. And then routines. I think of routines as essentially an analogous phenomenon at a collective level, that we as employees or colleagues in a given work setting or in a given organization, we develop interdependent patterns of practice and understandings about how to proceed for a given set of tasks, and we develop these, even if we don't intend to. We develop them over time. And there's if speaking of reading, if you're interested in this, this idea of habits and heuristics really maps onto this idea of system one thinking from Daniel Kahneman and Eamon Tversky, and comes out of both cognitive science and behavioral economics. And they contrast the systems one, very efficient, fast, intuitive. You develop these mental shortcuts for dealing with something like, treating a patient with upper respiratory infection. You very quickly develop this pattern. Here's how we evaluate. It's not something more serious. Here's how we're going to talk to the patient. Here's how we're going to treat it, and just these efficient patterns. Versus system two, which is this slow, effortful, conscious decision making. What am I seeing? This very present decision making. And again, I think that there are these analogies at the group level, with policies, standards, routines. I'd like to share a video, and I know this video is a little bit long, but this is a great example, because heuristics are very difficult to understand. And I think one of the important things that we don't realize is heuristics, once we establish them, can be very difficult to let go of. And there's a science YouTube channel called Smarter Every Day. Destin Sandlin, Destin, Destin is an engineer who has this channel. And let me just play this. Let me just share this.
Hey, it's me, Destin. Welcome back to Smarter Every Day. You've heard people say it's just like riding a bike, meaning it's really easy and you can't forget how to do it, right? But I did something. I did something that damaged my mind. It happened on the streets of Amsterdam, and I got really scared, honestly. I can't ride a bike like you can anymore. Before I show you the video of what happened, I need to tell you the backstory. Like many 6-year-olds with a MacGyver mullet, I learned how to ride a bike when I was really young. I had learned a life skill and I was really proud of it. Everything changed though when my friend Barney called me 25 years later. Where I work, the welders are geniuses and they like to play jokes on the engineers. He had a challenge for me. He had built a special bicycle and he wanted me to try to ride it. He had only changed one thing. When you turn the handlebar to the left, the wheel goes to the right. When you turn it to the right, the wheel goes to the left. I thought this would be easy, so I hopped on the bike ready to demonstrate how quickly I could conquer this.
And here he is, ladies and gentlemen, Mr. Destin Sandlin. First attempt riding the bicycle.
All right. So the faster I go, the better. Yeah.
I couldn't do it. You can see that I'm laughing, but I'm actually really frustrated. In this moment, I had a really deep revelation. My thinking was in a rut. This bike revealed a very deep truth to me. I had the knowledge of how to operate the bike, but I did not have the understanding. Therefore, knowledge is not understanding. Look, I know what you're probably thinking. Destin's probably just an uncoordinated engineer and can't do it. But that's not the case at all. The algorithm that's associated with riding a bike in your brain is just that complicated. Think about it. Downwards force on the pedals, leaning your whole body, pulling and pushing the handlebars, gyroscopic precession in the wheels, every single force is part of this algorithm. And if you change any one part, it affects the entire control system. I do not make definitive statements that often, but I'm telling you right now, you cannot ride this bicycle. You might think you can, but you can't. I know this because I'm often asked to speak at universities and conferences and I take the bike with me. It's always the same. People think they're going to try some trick or they're just going to power through it. It doesn't work. Your brain cannot handle this. For instance, this guy, I offered him $200 just to ride this bike 10 feet across the stage. Everybody thought he could do it.
No, you didn't understand. You didn't understand. So, this way. Okay. All right, just a second. All right, so, whenever you're ready. Yeah. Wait. No, you have to keep your feet on. Dude, all right, here we go. Wait.
I'm going to
Personal
jump ahead.
challenge. I stayed out here in this driveway and I practiced about 5 minutes every day. My neighbors made fun of me. I had many wrecks, but after 8 months, this happened. One day I couldn't ride the bike and the next day I could. It was like I could feel some kind of pathway in my brain that was now unlocked. It was really weird though. It's like there's this trail in my brain, but if I wasn't paying close enough attention to it, my brain would easily lose that neural path and jump back onto the old road it was more familiar with. Any small distractions at all, like a cell phone ringing in my pocket, would instantly throw my brain back to the old control algorithm and I would wreck. But at least I could ride it. My son is the closest person to me genetically, and he's been riding a normal bike for 3 years. That's over half his life. I wanted to know how long it would take him to learn how to ride a backwards bike, so I told him if he learned how to ride a backwards bike, he could go with me to Australia and meet a real astronaut.
Are you gonna give up? No. Go ahead. This is how it starts. Look at this. This is such a big deal. Get up, you got it. Did you see his brain get it? So in how many weeks have we been doing this? 2 weeks? In 2 weeks, he did something that took me 8 months to do, which demonstrates that a child has more neuroplasticity, am I even saying that right, than an adult.
It's clear from this experiment that children have a much more plastic brain than adults. That's why the best time to learn a language is when you're a young child.
All right, today's bike log. I can ride smooth, I can ride fast. I'm thinking the experiment is over. Okay, now I'm in Amsterdam, a city that has more bicycles than people. The question is, can I ride a normal bike now? I mean, I've spent all this time unlearning how to ride a bike. If I go back and try to ride a normal one, will my brain mess up? So I've tweeted a Smarter Everyday meetup, if you will, and I'm gonna see if somebody brings a bicycle and I'm gonna try to ride a normal bike. It's backwards, it's backwards.
This was one of the most frustrating moments of my life. I had ridden a normal bike since I was 6, but in this moment, I couldn't do it anymore. I had set out to prove that I could free my brain from a cognitive bias. But at this point, I'm pretty sure that all I proved is that I could only redesignate that bias.
So what you're not seeing is there's a group of people here looking at me, looking at the strange American. that can't ride a bike because they think I'm dumb. But I'm actually 2 levels deep into this because I've learned and unlearned. All right.
After 20 minutes of making a fool out of myself, suddenly my brain clicked back into the old algorithm. I can't explain it, but it happened in a very specific moment.
Got it. I'm back. Oh, it clicked. Hold on, it clicked. I got it. Okay, there it is. There's the moment. Okay, I can ride a bike.
I tried to explain this to the people around me, and they just didn't get it. They thought I was faking the previous 20 minutes, and I couldn't get anybody to believe me.
That looked like I faked that.
Hey, it's me,
That's good.
Destin.
Oops.
Welcome back to Smarter Every Day.
I'm going to, let's see, I'm going to cut. He just goes on to sort of talk about bias. And actually, I'll just mention as an aside, he talks about the bicycle riding as a kind of bias, that he had a mental bias. And I think that that also is instructive because it's not a bias per se. It's it's a heuristic that works under certain assumptions, certain conditions, and is maladaptive under another set. And I think that's oftentimes what we deal with in healthcare is we establish a set of heuristics that are adaptive at one point in time, and then, or seem to be, and then conditions change. I want to pull out 2 things about that backwards bicycle example. So, he has this existing practice and set of heuristics, that is riding a bicycle with normal steering. And to operate the backwards bicycle, he has to actively suppress that existing set of heuristics. And that's one of the things in general, I think, makes de-implementation different, is we've got an existing set of heuristics and routines that will assert themselves. And we have to do something to actively keep them from being launched. And it may seem like the bicycle example is not applicable to prescribing or to other low value practices, but I think it is very much. I think in a moment, especially when someone is busy multitasking, you're going to fall back on routines and heuristics, and it's all you need is some prompt to lock you into an existing set of routines. Anyway, so I think that's really important, is that de-implementation involves this suppressing these existing heuristics. The other thing I want to point out is that's really fascinating about this video is it illustrates how that old heuristic is still there. It never goes away. And he successfully suppressed it, through a lot of extreme effort. And please note, he was, that in order to establish that new heuristic and to suppress the old one, he was spending time, 8 months by himself in a driveway writing. It's this concentrated time. And he talks about distractions. Like if a cell phone rings, it interrupts him and he falls. And that is the type of thing that I think is, again, it may be less dramatic than with a bicycle, but is very analogous, that it doesn't take much. It would not take much to have us to have some sort of stressful event to have a heuristic reassert itself, or at a clinic level, some sort of like turnover in staffing, and to have an old routine reassert itself. I think that there are these analogies, and that's largely what this slide is. Just there are analogies at the organizational level, I think. And so again, with de-implementation, I think what's different than with implementation is all about establishing some new heuristic, largely where one didn't exist previously. And in de-implementation, what we're trying to do is really suppress or unlearn an existing heuristic. Some of the things that we can do potentially to counteract the effects of heuristics and routines on low value care, I think that there are opportunities for us especially in integrated delivery systems, to build in structures into our infrastructure. And by that, I mean into things like the electronic health record, or into policies and routines between practice units. So the example of the proactive e-consult is one. There's some great work Gary Prekop and others have done in pathology on reducing inappropriate testing. And one of the things that I think that they've done that's so good, and this is the second bullet point down there, pathology hard stops. is they include, when they put in hard stops for tests, what they've done is they've basically put in links to the relevant information elsewhere. They've looked for examples where the tests are duplicative, and then they give, they don't just prevent someone from reordering a test. They actually then link them to the original test results, and they're basically solving the clinician's problem and not leaving them at a dead end. The other idea, I think with these things in terms of suppressing heuristics is creating an alternative heuristic. It's like the backwards bicycle, having another way of steering, but to create what I would call an incompatible substitute. It's an alternative that essentially precludes the low value practice. And the example I think of that's just a great example of this is watchful waiting in the context of prostate cancer, where instead of more aggressive care, one option is to say, listen, we're going to evaluate this. We don't think this is going to progress. This is not progressing, in days or weeks. We can watch this. This is an alternative to surgery that could lead to impotence or could lead to incontinence. Those incompatible substitutes, something that creates an alternative path. I'll also mention at a policy level, the Abdul Latif Jameel Poverty Action Lab has this great, it's one of the few examples I know of where there's a program at a programmatic level. They've created tools for, and basically a model for when you've implemented a program to continue to evaluate it and to systematically de-invest or to de-implement a program if it turns out to be ineffective. And there's a great example of this from an alternative type of stove in wood burning stove in sub-Saharan Africa that turned out to actually increase respiratory illness. And they thought that it was going to be better. They thought it was going to be more fuel efficient and lead to less labor for the families, almost all women. And it turned out to be a serious health risk. And it's a long story, but that's a great example to see. And there's some fantastic resources there. And then I'll mention Chesterton's fence in a second. I want to move on quickly to asymmetry of outcomes. One of the challenges with de-implementation is what happens at the end. So you've got the provider who essentially, like in the case of Dr. Bott and Mr. Larson, Mr. Larson's anxious. And if Dr. Bott takes him off the inhaled corticosteroid, and then in the next several weeks or months, he has a breathing exacerbation and ends up in the emergency department, Dr. Bott knows there's a chance that he's going to attribute that to her taking him off of the inhaled corticosteroid, even if it has nothing to, even if she knows intellectually it's got nothing to do with it. And even if she has the backing of her, her clinical leadership and organizational leadership, there's still that anxiety that she could be blamed for this. Conversely, if Mr. Larson never has a case of pneumonia, there's no moment at which there's this recognition like, oh, Dr. Bott just saved him, just saved him from a hospitalization, possibly saved him from death. There's this asymmetry when you de-implement something. Oftentimes you are implicitly, you as the individual practitioner are implicitly assuming a risk of being blamed for some bad outcome. And generally speaking, there's no equivalent benefit. And I think that this has been, again, there's a certain aspect of this goes back to the evidence-based issue in this. There's an ad here from the 80s for mammograms, the American Cancer Society promoting mammograms. And I think that we as a public health community, we as a healthcare community, sometimes as a medical community, sometimes have contributed to this, where we have very black and white messages about practices. And so like with mammograms, for the longest time, there was absolutely unambiguous. Mammograms will prevent breast cancer. There's no nuance. There's no gray area. It's just more mammograms are better. And not only that, if you don't get a mammogram, you are mentally deficient. It means there's something wrong with you. So I think that we have contributed to that as a community. So again, I think with this asymmetry of outcomes, the asymmetry is for the individual clinician, the best outcome is nothing happens. You take the patient off the medication, there's no change in their symptoms. You don't give them the screening test, they never get cancer. And the benefit is, the downside is you take them off of it. And even if it's not because of that action, they have some bad outcome. I'm going to just jump ahead here. And Ken, let me just check a time check. Do I need to, am I going till 11:50, 2:50 Eastern?
Sure. Yeah, it'd be great to leave a little bit of time for questions.
Yeah, I'm going to try to wrap this up real quickly. I will just mention with asymmetry of outcomes, I think one of the biggest things is giving providers backup. Again, this was something with the that original example of the proactive e-consults with the pulmonary team. That was to my mind, one of the big things that did is that it gave the primary care providers backup. It wasn't them making this decision on their own. There was a pulmonary specialty team that was behind them saying, yeah, this is the right decision. And I think there are lots of examples from this where that sort of just a little bit of again, sort of morale, a little backup can make a huge difference. And then the other thing is, I think that one of the things that we need to do with at the patient level and the community level is just create this expectation that we are going to revisit these things over time. We're going to put you on, a beta blocker, or we're going to put you on a statin. That's not going to be forever. We're going to revisit this. There may be a point in time where that just doesn't make sense for you anymore. I think that those are important. The last thing I'm going to mention is psychological reactance. This is when people feel like their freedom is being taken away, and they respond with anger and mistrust. And again, I'll just to wrap this up, I'm going to jump ahead. But the important thing with reactance is, and this is something that we're all familiar with. Actually, I'm going to jump ahead a slide and then come back to this one just real quick. This is something we're all familiar with, and we just lived through it with COVID, with the mask mandates, and with the vaccine recommendations, where a significant portion of our population, of our community in the United States and elsewhere, viewed those mandates, and they became so mistrustful that they started, they developed alternative reasons, alternative rationales for why these things were being promoted. And as a consequence, we had this polarization where not only did evidence of, for example, the effectiveness of vaccines in preventing COVID infections and death, not only did that evidence not sway perception, we became so polarized that evidence actually was active, the promoting that evidence became a signal, became proof in and of itself that there was some sort of conspiracy, that there was some sort of effort to manipulate the public. While COVID was an extreme example, there actually is a long history with vaccines of this happening. The current vaccine, skepticism, and I use that hesitantly because it is sort of derogatory in some senses. But prior to the current vaccine hesitancy, there's been a long history of this. I think one of the important things is that with these two components, anger and mistrust, anger dissipates. People will get over it. They'll be angry for a moment, and then they'll get over it. Mistrust is very persistent. And there is a real danger in doing this, that we actually create this boomerang effect, which is exactly what we saw in COVID, where not only do people not, you say, I don't think this medication's not good. Not only do they not give up the medication, their commitment to it actually increases. And I think that this is a really high risk issue in the context of de-implementation. Check out, I linked to these slides from the Deo lecture, from the Birnbaum lecture, sorry, that Rick Deo gave in 2008. This is a really good, he has 3 examples that are just mind-boggling. I am just going to jump to the end. I think that there are some, with psychological reactance, I think one of the things that we need to do is to inoculate people, and that's at the patient level and at the community level, by talking about the fact, again, that practices will change. We will revisit medications. No medication, I'm sure there are some exceptions, maybe, maybe insulin for type 1 diabetes, there are some exceptions, but largely no medication is forever. There may be a time when it doesn't make sense anymore. And then I think another great article to read, incidentally, Brownlee and Kornstein, about anesthesiology. I think we can also help. We need to build, essentially build the foundation about why there are harms. Anyway, I'm gonna just I'll close up here and mention there have been a whole bunch of lit reviews on strategies to de-implement low value care. A lot of these are actually focused on medications. One of the things for the early career investigators out there, two of the biggest gaps that I see in the literature right now, I'd mentioned before that half-life effects. I don't know why we don't have those in every, medical, surgical, public health discipline. There are only, and I think maybe there are three examples. There's the Hall and colleagues. There's another example from medicine, and I think one from cancer. Oh, and it was something. It was like one conditioning, cancer maybe. There are just very few of these. I don't know why there aren't more, because we do need to understand how fast the underlying science is evolving in different disciplines. And then the other thing is these literature reviews on strategies. We're not getting at the mechanisms, and there's a lot of, I think a lot of the learning across studies and across settings, we're not getting the benefit from, because we're just reporting what percentage of audit and feedback cases are effective, what percentage of physician education interventions are effective, and that it's hard to draw conclusions from that. That's it. I'd be happy to answer questions. Thank you so much for the opportunity to join you, and sorry for the sort of rushed landing, as it were.
No, thank you. What a great review, philosophical, psychological, some science, history of science. It's all fantastic, and applying it to what we're trying to do. So now, please, folks, please type in your questions either into chat or the Q&A bubble. We do have a comment that our experience with daily aspirin for those without cardiovascular disease comes to mind.
Yeah.
And it takes time to get people off of aspirin.
Yeah.
And then the hope that general practitioners will stop prescribing more than 5 days of benzodiazepines. And just thank you for a thought-provoking webinar. Other comments and questions? Let me see if I'm missing anything.
Yeah, the daily aspirin is such a good example.
Here's something from Dr. Mike Steinman. Do you think that the most promising interventions for deprescribing should focus on changing heuristics or encourage, so type 1 thinking, or encourage more slow type 2 thinking?
Yeah, and I think a great question. And I think and I'm sure you're probably already thinking along these lines. I think it entirely depends, and it's something I think we should take into account, that dynamic. And so if we're trying to get someone, let me provide an example of unlearning, like effective unlearning. I have a colleague, interventional cardiology colleague, who did an educational intervention to try to reduce inappropriate cardiac imaging before non-cardiac surgery. And he did focus on just education, provider education. And bear in mind, this was a single site pre-post study, so that all kinds of caveats about, speaking of, generating bad data, bad findings, so Dr. Steinman, take this with a pinch of salt. But I think in that instance, one of the things that David Winchester did, my colleague, is that he tailored the education to the reason the providers were ordering the non-cardiac imaging, or the cardiac imaging for the non-cardiac surgery. And there were different, he looked into it, and there were different patterns among hospitalists, and there were different patterns among surgeons. And so he tailored the education, and it was just those decisions, at least as David described it to me. I'm not a cardiologist, but as David described it, that when they were ordering those tests pre-surgery, it wasn't a space where there was some time to focus on that, where it was not in a, in general, it wasn't in this, like the provider was juggling, responding to whatever, some other crisis on the side, or answering questions. And in David's experience, that was effective. Just that explaining, you don't need to do this anymore. This actually isn't helpful. It doesn't prevent cardiac arrest on the table. That was effective. And so I think thinking about the context, like, is both, are we delivering that unlearning in a context where people can absorb the information? And David was doing this, and as I understood it, some sort of lunchtime seminar, some sort of standing seminar where they could have back and forth. And then, so that context was amenable to unlearning. And then the decision-making context was one where the provider could take a step back. They weren't riding the proverbial bicycle where, there were 12 things that they had to get right at the same time. And I think in cases where they are riding a proverbial bicycle where they've got to juggle multiple things, those are the situations where I think it's just crazy for us to go in with provider education, or even worse, provider like motivation, as though providers don't give a damn, and say, listen, I'll pay you an extra $20, if you ride the bicycle backwards. I just think we're setting ourselves up for failure. I don't know if that makes sense, but it depends, I guess. Yeah.
Okay, well, thank you. Do we have time for one more question? One that came in that is your thoughts on situations where deprescribing is indicated, so there's low value or harmful medication use, but the adverse effect of deprescribing, like adverse withdrawal events, are framed as relapse.
Mm-hmm.
Relapse of a condition. I don't know if you have a reaction.
So, and actually, so no, and I don't quite follow. Say again.
I guess it's a little bit of a framing question, is it, well, we're kind of at the top of the hour, so.
I will I just saw in the two quick comments on the chat. One with supplements, naturopathic things. I just think that that's a huge issue, and I've got a neighbor who's a naturopathic doctor, and I want to be on good terms with my neighbor. It is really, really challenging, and it's hard to navigate. And I don't think there are good answers, and that is a huge market and the huge implications. And then with the guidelines constantly being updated, I think this is, it's really dangerous for us to assume that things, like modern medicine is so much different than medicine 20 years ago. And we've got all these challenges that are totally unique that no one's ever faced before. And I think a lot of times we blow it out of proportion. The number of guidelines that are out there and the frequency with guidelines change is crazy. And that's, again, something with this, that goes back to the half-life effects. I think we need to understand the sort of velocity of change and the scope of, that's just something we have to get our hands around, because that's going to be crazy making. We're setting ourselves up for failure, I think.
Thank you so much for this. And thank you everybody who attended. There will be a recording on the USDN research or USDN website, and you will also, for those of you who are attendees, will get a evaluation survey in the email. We will have another webinar on January 16th at 2 Eastern, Dr. Joseph Ross from Yale. And then for those of you who are part of our junior investigator program, there's a 30-minute session with Dr. Helfrich right now, immediately following this one, and a separate link has been emailed to you. And thanks, everybody. Have a great day. Have a great new year. Take care. Thanks, Dr.
Happy holidays, everyone. Take care. Thank you so much.